Hello, everyone. Welcome back to class. So this is our first screencast for week number 4. So this week we have another discussion topic, and that's due the first one by September 29th. We also have a homework, which is due on September 29th also. Now, I may, depending upon how long this presentation goes, break things up into 2 screencasts. So a 4.1 part 1 and a 4.1 part 2. So you'll notice that listed there. However, if the screencast doesn't run that long, it'll be revised and it'll just be a main 4.1 screencast. So for discussion number 2, what's due by September 29th, you're going to identify one common injury or disease that you evaluate and treat in your place of employment. Now, if you are not currently treating individuals, that's fine. What is a common injury or disease that if you were in full-time clinical practice that you would be evaluating and treating? What you're going to do next is report 1 to 2 known risk factors for that selected injury or disease. Now, what's interesting is some risk factors that are thought to be related to disease or injury have not been assessed prospectively. So I'd like you to assess the literature for studies that have either supported or refuted the risk factor, presenting 1 to 2 references in your post. For example, if I was interested in ACL injuries in female athletes and looking at the monthly cycle, are there points in time associated with elevations in certain hormones that increase the risk of ACL injury? So I might assume, if I didn't have knowledge already, I might assume that female athletes may be at a greater risk for ACL injury during a period of time where there is higher levels of the hormone relaxin. When I go to the literature now, what I might find is studies that actually refute that female athletes are not at a greater risk of ACL injury dependent upon the time of hormone levels. Does that make sense? And so you can see that it can have a variety of things. I know that not everybody is a sports physical therapist or an athletic trainer. And so if you're looking at any particular injury or disease, what are those risk factors that are out there? And can you then cite something that supports that risk factor or refutes it? And then your response, which will be due by the following week on October 3rd, so kind of midweek area, you're going to review the reported risk factors from 2 of your classmates. Then you can review the literature also for additional studies that either support or refute the risk factor. You'll provide a reference to each classmate and the keywords you utilize to perform your literature search. Now, ideally, what you're going to be doing is you're going to be trying to look for risk factors that maybe build upon the discussion 1 topics. See, what we're trying to do here is kind of help you try to build towards something you might want to do for your project for this term. Now, obviously, what you discussed in discussion number 1 does not have to be what you're going to be writing upon and presenting upon during this term. But if it's something of interest, now's your opportunity to look at potential risk factors, practice searching the literature, identify what that risk factor was, if it's supported or refuted by a particular piece of literature. And then you're asking then, well, why am I doing a response post where I am providing something else? Well, The reason is there is oftentimes people who have similar professional backgrounds or interests. And I may find one piece of literature, but somebody may, because they know the literature also really well, find something really interesting that would further help my study. And I'm trying to get you thinking in that process of working in teams. Because again, some of the best work that I've ever done has not been something that I've individually done. I may have led it, but I've relied upon the skills and knowledge and expertise of those around me. Okay, so let's talk about risk. If this video was playing, and if you're going to go into academics in the future, I would recommend downloading this PowerPoint and saving it and saving this particular video. It is the perfect way to illustrate risk. What's going on is the guy is obviously doing something stupid where he's balancing himself between two cars, and then it's got to be a made-up video. I don't think anybody would be this stupid to do this, but he basically runs into a pole. So he gets slammed right in the crotch, and it illustrates perfectly. As healthcare providers, we're dealing with the probability of something bad happening. People are at risk for disease. What can we do to either from a preventative aspect help to reduce the risk of disease? What can we do as researchers to identify potential risk factors for disease? And then what can we do, again, in our clinical roles to help reduce the risk of subsequent disease? So with studies of risk, we are going to be looking at estimating risk by observing relationships between exposure to possible risk factors and subsequent incidence of disease. Now, the prospective study is the most powerful way to determine whether exposure to a potential risk factor results in increased risk of disease. And so the investigator is able to observe a group of people at baseline who do not possess the disease or are not injured, and then are able to observe groups from that population, those who may possess the risk factor or who are exposed to the risk factor, and then those who are not exposed. We'll see some examples of this in just a bit. Now, the prospective cohort study is the best way, but prospective cohort studies are not always possible or not always ethical to perform. So there are study types we can't obviously do because of ethical reasons. For example, we could not ethically ask a group to increase their BMI to the level that's considered obesity and then have them maintain that BMI while we observe them over time for incidence of cardiovascular disease. We can't require an experimental group to initiate a smoking habit. Just like we couldn't, what's more popular now, vaping. We couldn't require a group of teens to start vaping. But there are ways that we can potentially look at how things like smoking or vaping can affect health through non-prospective cohort epidemiologic methods. We couldn't ask an experimental group to purposely perform risky driving behaviors. So it's unethical to impose possible risk factors on a population of healthy people. Many people would also be against having their behaviors or diets drastically changed. And so think about that. You ask somebody to do something, how many people are not going to follow through, which would then give you poor results, results with bad validity. The study types described in the prior slide would also need to be conducted for many, many years. Maybe not the driving one, but for sure the BMI and the smoking ones. Why? Well, because people don't immediately develop disease with only a small exposure to smoking, or people don't develop a chronic health condition if they are obese for a short period of time. Or if they lose weight, there can be a reversal in different health states. So to really do a prospective cohort study to look at some of these things, you need lots of money. They're time intensive. You need a staff. You need people that are grant supported, and doing something like the Framingham type of study where you are following generations over time to study how different factors affect heart health. So what we're talking about today, and we talked about a lot of different study designs last week, and what we're really focusing on today are some of the main ones that we as healthcare providers represented in this class that we would be involved with. And those are the cohort and case control study designs. Now, prevalence studies, very common, very easy to do also. We've talked about those. I'm not going to be talking about those anymore in this particular lecture. Again, we explored a variety of different study designs last week. Many of those, though, would be the types of things you might see the traditional epidemiologist involved with. Not to say that you wouldn't be involved with, but I'm trying to look at the things that the vast majority of you, what you might be involved with. So with an observational study, in these studies, the researcher gathers data by observing and not intervening. And cohorts are the cornerstone of this. The cohort, again, is that group of people who have something in common when first assembled and who are observed for a period of time. Observations of a cohort should fulfill 3 criteria in order to provide sound information regarding the risk of disease. That is, they do not have the disease or the outcome of question at the time that they are assembled. They should be observed over a meaningful period of time in the natural history of the disease in question. So, for example, 30 to 40 years may be necessary for heart disease, but 6 months may be adequate for a sports injury. All members of the cohort should be observed over the full period of follow-up, or methods should be used to account for dropouts. So I think we saw this slide previously here. This is the definition of the prospective cohort study. And as I mentioned before, what we're doing is having a population, and within that population that we're observing, there are those who are exposed to a risk factor or possess a risk factor, and another group that does not. And then we follow them forward in time to track the incidence rate of disease in each group. And then what we're going to be getting or calculating is the relative risk or the risk ratio statistic. These are good for large populations followed over several years, or in my example, populations over a short period of time looking for risk of athletic injury. Usually you're focused on more common diseases or disorders. An example could be looking at how computer use increases the risk of carpal tunnel syndrome. So let's say you were looking at individuals who are hired for a particular line of work, and your job was to evaluate the risk of carpal tunnel syndrome. Is there, based upon the workspace, the type of computer, the type of keyboard that one uses, are they at a greater risk for carpal tunnel syndrome? So the prospective cohort study, you can see the diagram here. And basically what you're trying to do is break people into one of two groups, the exposed or not exposed. And sometimes I like to think about them as, instead of exposed, the at-risk group, and the not exposed being the reference group or the lesser risk group. Here's that example from last week where we have categorized people into an at-risk or lesser risk group based upon their performance on a isokinetic strength test. And we can see then the incidence within each group, where it is 50% in one group and 20% in the other. Classic cohort study example is the Framingham study. Framingham study, if you're not familiar with it, looking for risk factors associated with coronary heart disease. Initially followed people, about 5,000 some people who did not have a coronary heart disease diagnosis, and they've followed people for many generations since that time. And the risk of developing CHD is associated with some of these findings. Elevated blood pressure, right? Think about elevated blood pressure and how blood pressure can potentially damage endothelial linings. Same thing with high cholesterol levels or high LDL levels and smoking. Those things are all potential things that cause endothelial damage and then can allow for plaque buildup. Same thing, glucose intolerance, or maybe what we might think about as excessive sugars causing damage. And then one other one that the book cited here was left ventricular hypertrophy. So increased ventricular size, does that impair then the pumping capabilities of the myocardium? So comparing prospective and retrospective. A prospective study, again, like we talked about, assembled in the present and followed into the future. There's also the retrospective or historical cohort. And this is really a fascinating area, and I'm really jealous of those people who have access to this type of data. So a retrospective cohort, you identify people from past records, and then you follow them forward into the present. And so people will utilize these large data sets and be able to really do some tremendous things. Historical cohort studies utilize computerized medical databases and population registries. What's nice is they take less time, they're less expensive to perform, and they're much easier to perform. Why is this? Well, I think I mentioned to you I participated in a thematic poster presentation at an American College of Sports Medicine conference. And there was 5 or 6 of us up there. We had our posters up. I had 82 subjects for my prospective cohort study. That was like 4 or 5 college volleyball teams. So it took a few years to collect that data. There were people that had 3,000, 5,000, 10,000 subjects. And it first got me thinking, oh my goodness, how are you able to get all this data? Because if it took me a couple years to get 82, how many years would it take me to get 10,000? Well, what they had available to them was large data sets. So they aren't having to do the work of recruiting people. There isn't the cost because the data is already there, and so now they're just crunching the numbers. I am jealous of people that have that type of access. It's wonderful. I wish I could be doing that type of work. If you ever get the ability to access large data sets like that, I would highly recommend it. Disadvantages, though, is you cannot undertake a study of factors not recorded in the database. So there may be things that are just not there that would give a better picture or a complete picture. And then there's a possibility of bias if data was not collected in a standardized manner. So here's that retrospective design. What you have in the present, you know that there is disease, whether it's no disease or disease, but you don't know what groups they're in. Why? Because you haven't assembled people yet or categorized them into an exposed or not exposed group. So you're in the present, so you need to go back to the past first, find them at baseline when the data was collected, and then categorize them and then come back to the future or back to the present and then make sure, or I should say, attribute them to one of the two groups. So here was the example I gave last week where you're working in a skilled nursing facility or some sort of retirement community. Your patients are having falls. You want to know why they're having falls. So you go back in time when they were first admitted, and then you look at different factors that were measured, and then you can then come back to the present. How do you know if something's a retrospective cohort study? Well, it oftentimes tells you in the title. And if it doesn't tell you in the title, you can find it in the methods in the abstract usually, or within the methods section. Here is a classic retrospective cohort design, or I should say, maybe not classic is what I'm trying to say. What I'm trying to say is this is a retrospective cohort study that really caused a lot of, or inspired a lot of future research. And so with this particular study, published in the North American Journal of Sports Physical Therapy, later renamed the International Journal of Sports Physical Therapy, they looked at one professional football team and they got access to their functional movement screen data. And then what they did is they defined what an injury was, and an injury for this particular study had to be something significant, leading to 3 weeks or more of time on the disabled list. They found that people with a lower score on the functional movement screen, and so for those of you who don't know what it is, it's a series of different movement tests, and they're scored based upon how well somebody can perform the test. Anyways, people that had a lower score were at a greater risk of having a significant injury. Now, this is where things become very important for you as a researcher as you think about what the data is, what kind of story you're trying to tell. Their definition of injury included any injury that was either contact or non-contact in mechanism. Well, why do we do a study like this? We do a study like this because we want to see if we can identify people who are at risk because we want to potentially be able to intervene and improve their scores, right? The big question is, can you improve scores enough to reduce the risk of injury due to a tackle football? And that's kind of the big challenge. Interestingly, many studies since that who tried to replicate this design have not been able to show that score holds up. Another issue with this retrospective cohort design is that these 3 authors that are listed here, these authors were not the ones administering the functional movement screen. Now, there's nothing wrong with the fact that they didn't administer it. They just have to trust that the individual who performed the test did so in a valid and reliable way. All right, I'm going to go ahead and stop here and we'll pick up with part 2.